morning and welcome to day 2 of the Kyiv Summer Stroke Summit. Today we continue our program with a keynote lecture by Professor Natalia Rost from the United States, President of the American Academy of Neurology, Professor of Neurology at Harvard Medical School, and former Chief of the Stroke Division at Massachusetts General Hospital, a leading expert in brain health and long-term stroke outcomes. She will present on brain health across the lifespan and its impact on stroke outcomes. This perspective is especially important as stroke care continues to expand beyond acute treatment toward long-term prevention and recovery.
Шановні колеги та друзі, dear friends, I'm delighted to be here with you today, and it's a great honor for me to join the 2026 Kyiv Summer Stroke Summit and the important conversation on brain health, both as a practicing stroke neurologist and as president of the American Academy of Neurology. I would also like to take a moment to congratulate Drs. Flomin and Gulayeva on organizing this meeting for so many years in a row. For those of you whom I haven't met, I'm a vascular neurologist and a clinician scientist at Massachusetts General Hospital in Boston and professor of neurology at Harvard Medical School. And as many of you know, I grew up in Crimea, Ukraine. But today, I am here also to represent more than 44,000 neurologists and neuroscience professionals who are members of the American Academy of Neurology. And I am proud to say that nearly a quarter of our members reside in 146 countries outside the United States. Stroke is a major contributor to brain disease, and it is our mission to work together to promote brain health for all. In this way, joining this conversation today brings about a truly global significance. So let's get started.
Brain health for all is a phrase that the American Academy of Neurology has been using in its materials for patients and the public over the past few years. It is my great pleasure that on behalf of the American Academy of Neurology, I would like to present to you a report titled The Brain Health Imperative in the 21st Century. We have a saying at the American Academy of Neurology, minds on a mission. About 2 years ago, the Academy unveiled its 5-year strategic plan. As part of the plan, we reaffirmed our commitment to enhance member career opportunities and promote brain health for all. Promoting brain health is a core component of our mission. The Academy of Neurology takes this very seriously. For many years, it has been working to improve public health from the perspective of neurology and brain health. We remain a professional organization that is strategic and dynamic. Our goals, according to our strategic plan, are to grow a diverse neurology workforce, strengthen neurologic practice, promote neuroscience research, and improve neurologic health. Regarding the Brain Health Initiative, the goal of improving neurological health has many approaches and objectives aimed at increasing public and member engagement in advocacy, developing validated brain health resources for both practicing physicians and the public, and establishing the American Academy of Neurology as the leading source for brain health resources. So what is the American Academy of Neurology's Brain Health Initiative? As you know, the Academy has been active in this area for many years, practically for decades. As many years ago, we launched initiatives to engage the public, patients, and their families in protecting their neurological health. In particular, we distributed bicycle helmets to children in Minneapolis. We've developed a range of materials for the public, including a professional journal that now has a whole collection or portfolio of publications, as well as a series of podcasts. And I'd like you to check them out because they're very interesting and educational. And in 2022, the American Academy of Neurology made a strategic decision to launch a brain health initiative because neurologists are doctors who treat the entire brain. not just specific neurological diseases. We know that when we study neurology, we often focus on just one specific topic. For example, my specialty is vascular neurology, so I mainly deal with strokes, stroke diagnosis, stroke treatment, and rehabilitation. However, the most important thing is stroke prevention. We all know that it is much better to prevent a disease than to treat it, especially when we're talking about the catastrophic consequences of a stroke. So the Brain Health Initiative aims to promote the concept of preventive neurology. It was launched in 2022 at our first Brain Health Summit, which took place in September in Washington, D.C. Our goal was to establish preventive neurology as a field and to strengthen the Academy of Neurology as a leader in brain health and preventive neurology. Our idea is not simply to solve all the problems on our own. We know that neurology is a subspecialty of a large medical community and that neurologists can be promoters and advocates for brain health. But we're also skilled at engaging other stakeholders and representatives from other medical societies, from pediatricians to internists, geriatricians, and specialists in other fields to improve brain health. We have engaged in this work for the past several years. I would like to specifically emphasize the brain health imperative in the 21st century. This is a call to action, and this phrasing is the AAN Brain Health Platform and Position Statement. And in 2023, an article was published that is now in open access, so I highly recommend reading it. You can familiarize yourself with the platform proposed by the American Academy of Neurology, a group of professionals that pay special attention to how the concept of brain health is promoted in greater society. As you know, there are many misconceptions and misinformation regarding health in general and brain health in particular. We also know that people generally really want to stay functionally active and healthy, and they're looking for different ways to achieve that. So they often come across unofficial, unprofessional sources that promise them miracles and incredible methods for achieving brain health. So I think it's time for us as professionals to take control of this process and collaborate with other experts in the field to establish an ecosystem where brain health is accessible and attainable for everyone. One step the American Academy of Neurology has taken in this direction was to formulate a definition of brain health that is specific to neurology. Why is it so important? You can find many definitions of brain health in the literature. Some are overly complex, some overly simplistic. And we felt that we needed to reach a consensus. So, for a joint statement and in the context of the American Academy of Neurology's Brain Health Initiative, we assembled a group of stakeholders from various medical specialties, ranging from prenatal development and pediatrics, as well as adolescent health specialists, to professionals working with the adult population and elderly patients. We asked these experts to identify the key elements of brain health. And through a special process called the Modified Delphi method, we developed a definition. The American Academy of Neurology defines brain health as a continuous state of attaining and maintaining the optimal neurological function that best supports one's physical, mental, and social well-being through every stage of life. This is our operational definition for the entire field of neurology and other specialties, which allows us to understand the key components we need to focus on to improve brain health. Another key component highlighted in this is the Academy of Neurology's lifespan approach. The concept of a lifespan is not entirely new to the vision of brain health. We know that our brain health is linked to our well-being throughout our entire lives. However, the American Academy of Neurology has developed a very specific approach to this, and we have proposed an action plan for each stage of life. Moreover, we do not divide life stages according to specific age cutoffs, as we know that the biological age is now considered a rather artificial concept. And as stroke specialists, we know that some people in their 80s have a brain condition more typical of someone in their 60s. And vice versa, we see patients in their 30s whose brains look like those of very elderly people. Therefore, we do not set any specific age limits in this concept of brain health. Instead, we view everything as a continuum that begins with fetal development and transitions to childhood development. The plan and goal at this stage is to develop best possible foundation. Moving on to the youth adolescence, we hope that by this stage a person will have reached their ideal individual potential. And when we talk about individual potential, we understand that some individuals are born with certain brain pathologies or have experienced brain diseases in their childhood. However, this does not mean that they cannot reach their own individual potential and optimize their brain health throughout their lives. In adulthood, we hope to proactively prevent brain injury and maximize the brain's potential. As we transition into maturity, we aim to provide effective intervention, rehabilitation, and recovery, even in the presence of existing brain damage. And as we move into old age, a cohort we refer to as platinum in our internal communications, we aim to optimize quality of life and ensure independence and fulfillment, because every person deserves brain health. The pillars of the American Academy of Neurology's Brain Health Initiative are science, patient care, public education, and public policy. Let's start with science. The American Academy of Neurology is a scientific organization. We are guided by science in everything we produce for physicians, patients, and the public. Therefore, we believe that within this pillar of science, we can accelerate scientific discovery in brain health through cross-disciplinary collaboration. We should collaborate with all subspecialties within neurology, as well as with every medical specialty in general, and break down the barriers that exist between different medical specialties when we talk about brain health. As for patient care, that is our mandate. As neurologists, we are authorized to provide brain care services, so brain health and its optimization are part of our scope of practice. Therefore, it is our duty to optimize brain health through integration of preventive care practices. And for this, we need connections with doctors in other specialties, pediatricians, internists, family physicians, geriatric specialties, and representatives of other medical specialties. Public education is a very important area and a pillar of the Brain Health Initiative. We must enhance public and patient engagement to advance public policy in brain health. In recent years, we have realized that patients are deeply invested in their own brain health, and they are also looking for opportunities to get involved in this process. We also know that politicians listen to their voters, and patients and their family members who are in fact the voters can, at the local level, influence, voice their concerns, and thus bring these issues to the forefront. This brings us smoothly to the pillar of public policy, and we know that to advance policy in the area through working with legislators on federal and state levels, and this applies to both the United States and other countries, we need collaboration between policymakers and the public, and we must ensure that the public is well informed in this area. One of the particular elements of the AAN Brain Health platform is the Brain Health Vision, and we have proposed this vision through 2050 in alignment with other priority areas such as dementia and others. We are pleased that we were able to formulate this vision at the very beginning of the initiative, and we also understand that this vision may evolve as new data emerges and the overall situation changes. However, the vision addresses very specific elements that neurologists, as champions of brain health, can influence in collaboration with other medical specialties. I invite you to explore these elements. 1, we are deeply focused on science and research in the field of the brain, and we hope and anticipate that scientific research in this area will enable us to accumulate a critical body of knowledge and scientific breakthroughs that will allow us to lay the foundation for brain health. We hope that preventive neurology will thrive as a cross-disciplinary field that develops new leaders in brain health. And we hope that educational programs will emerge that focus on preventive neurology in a similar way to what is currently happening in the field of preventive cardiology and other medical fields. Number 3, we hope that evidence-based practice guidelines for brain health for all ages will be developed and continuously updated. We need to ensure that these are incorporated into the practice of all specialists and serve as a reliable source of information for our patients and their families. We hope that brain health visits will become standard in medical practice and serve as part of a well visit at every stage across lifespan. Currently, annual medical checkups or even regular checkups for children include some components of a neurological examination. However, we want to establish a model in which brain health visits are incorporated into standard medical practice for children, adolescents, young adults, and all throughout the lifespan. We hope that education on brain health across the lifespan will become widely available and result in a highly aware and engaged public, enabling us to advance policy solutions. Ultimately, while this may be very specific to the United States and its approach to public health, it can also be adapted and applied to other public health systems, whether in Europe, Asia, or Africa. We believe it is necessary to have a national action plan for brain health. In the United States, one of the best known of such plans is the Alzheimer's Action Plan, known as NAPA. This action plan helps guide scientific research in the field of Alzheimer's disease, and we hope that the National Brain Health Plan will be established to guide scientific research and set priorities for brain health in general. Although we have set 2050 as our target for the plan, we still hope that certain elements will emerge simultaneously rather than sequentially, and therefore some key milestones may occur sooner than 2050. I'd like to take a few minutes here to talk about the AAN Brain Health Summit. This event has been one of our key achievements and a major tool for launching our initiative in 2022. We've already held 3 annual summits, and we're planning the next one for September 2025 in Washington. This summit has become an event where we celebrate our collaboration with stakeholders from various areas of the public and private sectors. Within the Brain Health Summit, we outline the summit's theme, and at the end of the summit, we formulate an action plan for the coming year. Therefore, this event serves as a platform where each participant has the opportunity to promote their initiatives in the field. The summit serves as a check-in for all participants. in a way that brain health in action gets to be rolled out. I'd like to show you a few slides where you can see the many stakeholders who participated in our summit. For example, this slide shows participants from last year. As you can see, we have representatives from the government, notably from the National Institute of Health. We had representatives from the Centers for Disease Control and Prevention. We invited a large number of professional organizations in the field of neurology and patient organizations. Foundations were also present, such as the Michael J. Fox Foundation, the American Heart Association, the Epilepsy Foundation, the Tourette Syndrome Association, and other professional and nonprofit organizations. We also invited participants who play a critical role in brain health, including our colleagues from the American College of Obstetricians and Gynecologists, the American Academy of Family Physicians, as well as major groups such as the American Association of Retired Persons, AARP, who are very interested in brain health issues among middle-aged and older adults. This collaboration allows us to disseminate information and helps to engage the public. It creates a unique environment where many fruitful collaborations emerge among all the participating organizations. There were also many representatives from major American medical institutions from virtually all geographic regions of the country, and all of them were very involved in the work of the American Academy of Neurology. So, what do we do for practicing physicians at this stage? We are still currently in the early stages of gathering scientific data, so we do not yet have a formulated practical recommendation. If someone claims to have such a practical guideline, it means that organization has not done its due diligence, as we are working very hard on this but are not yet ready to publish such material. However, within our academy, we publish what we call emergent issues in neurology. One of such articles from last year went online in December and became available in January of this year. Its title is The Neurologist's Role in Promoting Brain Health. I strongly recommend that everyone read this article. It is relatively short but very practical. The approach proposed in this publication is based on new data regarding brain health and is aimed at both doctors and patients. For doctors, we offer this acronym, Safest Brains, which is a combination of the first letters of 12 statements that are the pillars of brain health and for which there is scientific evidence. So I strongly recommend reading this article. It highlights the importance of sleep, affect mood and mental health, food, diet and supplements, exercise, supportive social interactions, trauma avoidance, blood pressure, metabolic and genetic risk factors, affordability of and adherence to treatment regimens, infection, negative exposures, as well as structural and social determinants of health in general. Once again, I highly recommend that everyone read this article. I hope you enjoy it. We also took this evidence-based article and developed guidelines for patients outlining 12 ways to build a healthy brain. This material is published in our open access scientific journal, which you can subscribe to read this article. It also happens that patients come to the doctor and ask for some specific steps they need to take to improve their brain health. So for this purpose, we have also developed a sample questionnaire that can be used for screening to assess brain health. The questions in the questionnaire cover sleep, diet, exercise, and other factors. So this is just the beginning of a long journey, and we don't have all the answers yet, so we don't have enough scientific evidence. I want to emphasize once again that no one has it. If someone tells you they do, they're most likely referring to only a small part of it. In particular, the American Heart Association is working very actively to publish guidelines for primary care physicians regarding brain health and stroke prevention. And it is very important as they focus on vascular factors. However, even these guidelines do not cover the full spectrum of brain health. Before I finish, I would like to highlight some achievements within our initiative. As you know, Dr. Ralph Sacco, who was one of the founders of the initiative and a stroke neurologist, served as a president of the American Heart Association and the American Academy of Neurology, established a scholarship fund for brain health research. And on this slide, you saw the last two scholarship recipients. My slides skipped one, and here you see the title page of the AAN Brain Health Initiative. I highly recommend visiting the website. It is packed with content, constantly updated, and can serve as a valuable source of resources and tools for you to stay informed about the latest advances and developments in brain health. We would very much like to see you as a visitor to this website. With that, I would like to thank you for your attention. I know that our time is very limited. This summit is always a very important event for me as a participant, and I hope you have a wonderful time listening to the rest of the talks. Thank you.
We now move to plenary session 3, which will focus on intracerebral hemorrhage and neurosurgical approaches in acute stroke. We begin with a lecture by Professor Charlotte Cordonnier from France, Professor of Neurology at Lille University Hospital and Head of the Department of Neurology and Stroke Center, and a leading expert in cerebral amyloid angiopathy, who will address current priorities and clinical action points in intracerebral hemorrhage.
Dear colleague, it's a real pleasure to talk to you about intracerebral hemorrhage. The concept is really to go through why we should take care of those patients as a medical emergency. And I am Professor Charlotte Cordonnier. I live in the north of France in a city called Lille. And I send you a lot of positive thoughts in those still difficult time. And as I say every year, but we will keep saying it, and hopefully it will work. Let's hope to see each other in real life next year. So what about ICH? Well, first of all, those are my disclosures, and this reflects that in the field of ICH, there are very few investment of pharmaceutical industry, because most of my disclosures are either related to ischemic stroke or are based on French Ministry of Health related to ICH. So ICH is roughly 28% of all strokes worldwide. Its proportion varies across the globe. In France, it's about 15%, and it's probably more in Ukraine. I don't have the exact figure, but even though it represents a less frequent cause of stroke, it corresponds to nearly half of all disease-adjusted life years lost due to stroke. So there's a discrepancy between the prevalence and the severity, and it's because we are still very much lacking of evidence-based treatment. One of the top risk factors is uncontrolled high blood pressure. The way we see ICH is probably a bit problematic because you see that we often see it as a a ball that is growing in the brain, full of blood. It's a neurological emergency. It's a life-threatening event, but this leads to a much more complex cascade of events than just looking at this as a growing hematoma. And this cascade of events is going through mass effect, excitotoxicity, necrosis, but then there's blood-brain barrier permeability, there's some extravasation with a recruitment of inflammatory cells, especially neutrophils, nets, that leads to apoptosis, but also that leads to specific cell death mechanism due to iron that is contained, of course, in blood, which is spheroptosis. So while we will focus on saving the life by fighting hematoma expansion, we have to keep in mind that we will have to associate different strategies to counteract this cascade of event. And there's one ICH, but there are several targets. There's expansion, we mentioned it, but there's also intraventricular hemorrhage. And also there is perihematomal edema that might be a very interesting target. And of course, there is secondary brain tissue damage. So all those steps will have to be targeted consecutively, sequentially, if you prefer, to really have an impact on outcome. So first, there's blood pressure management. Indeed, the systolic blood pressure should be lowered below 140 in the golden hour following admission. But the tricky thing is that we should not go below 130 of systolic. Otherwise, we will have more side effects, especially on the kidney. And we have to do that as soon as possible. We can use intravenous antihypertensive agents with short action time. So, for example, in my institution, we mainly use nicardipine. And we really have to focus on implementing procedures and evaluating our process. We did it for IV thrombolysis, and it worked. But we should also do it for ICH. ICH is even more a medical emergency than IV thrombolysis because you cannot reverse the process. So monitor your door to target, and it has to be below 1 hour. We should avoid blood pressure variability. We should avoid brutal drop of blood pressure. It's probably avoiding more than a 90 millimeter of mercury drop. And this works, and this is part of American but also European guidelines for patients who are really admitted early because it fights hematoma expansion, and the challenge of hematoma expansion is really within the first few hours. The studies that are based that we based this recommendation on were when people were admitted within 6 hours, but with blood pressure at admission between a systolic between 150 and 220. So for those patients who have much more than that, we don't really know what to do. At least we cannot apply those evidence-based guidelines. What else can we do? Well, probably we should go in the direction of a more personalized target with multi-organ evaluation. So it's a slightly futuristic approach of how we should manage blood pressure at admission. But first of all, we only base our recommendation on systolic blood pressure. But remember that it was performed like that in the international studies, so that it was easy to implement in our stroke units. But systolic only is probably not the right physiological parameter. So in looking at data from the Interact family of studies, you can see that the best strategy is probably to identify a magnitude of decrease of blood pressure rather than a single target. And this magnitude is probably around 40, 50 millimeter of mercury. And as you can see, there's a kind of G curve. If you drop your blood pressure by more than 70 millimeter of mercury, you may have some side effect. And if you drop it below 30 millimeter, you probably have no effect. But these targets probably influenced by kidney functions, probably influenced also by the brain parenchyma and the weight of small vessel disease and cerebral perfusion. So we have much more to do in terms of physiological evaluation to better personalize our target. The second step is anticoagulation reversal. Once again, it aims to limit hematoma expansion. According to what you have access to, you can use prothrombinic complex concentrate, PCC. When you have an antidote for dabigatran, you can use idarucizumab. We do not use in France andexanet alpha. And here, the importance, of course, if you have vitamin K antagonist, you use prothrombin complex concentrate and vitamin K. But once again, here, time is brain. And so the door to reversal should be below 60 minutes. Once again, you have to monitor that and you have to improve your procedure if you do not fit into this challenge of the golden hour. All of that needs to be done in a dedicated team in a stroke unit environment. A stroke unit or a neuro-intensive care remains the first treatment for ICH patients. I mean, there's no contraindication of stroke unit care. There's no allergy to stroke unit care. I know that the only limit is to have access to a bed, and this is another chapter of what we can discuss, which is how to influence stakeholders and really lead the movement to more stroke unit beds in each of our countries. But those stroke units enables to screen for dysphagia, to prevent vein thrombosis, to promote multidisciplinary management, and to provide early rehabilitation. But it also provides an important element, which is with the experience to avoid early limitation of care and to be aware of a self-fulfilling prophecy that has been impacting the prognosis of ICH across time. And it's especially in the European stroke organization ICH guidelines published last year, we really emphasized the fact that within the first 24 hours, sometimes 48 hours, we should really be in an active care strategy and taking time to decide what the prognosis is. So this is probably one of the most important thing to take back home when you manage ICH patients. And then, of course, there's blood in the brain. We mentioned that having blood in the brain is not a good idea. You show all the cascade of events that is progressing because of blood has nothing to do in the brain parenchyma, and all its components are so pro-inflammatory. But of course, it's a good idea. But we are in 2026, and from a technical perspective, we are still we have still progress to do. So some patients may benefit from surgery, but it's not the first thing to have in mind. The patient arrives, you do imaging, you see blood. The first thing you have to do is not to call the neurosurgeon. The first thing you have to do is admit in a stroke unit and go for your golden hour, target hematoma expansion, reduce blood pressure, reverse anticoagulation, and then evaluate the situation. And you might request a neurological consult after that. So you see that there's such a lot of work to perform on our process, in-house protocol, to see who you call when you see blood on a CT scan or on an MRI. So you might want to request a neurosurgical consult. What about the drainage of hematoma? Does these patients need external ventricular drainage? Is there room for decompressive craniectomy? What we can say from more recent studies is that lobar ICH that are very close to the cortex, that are more than 30 ml, might benefit from a mini-invasive surgery if you perform it within the first 24 hours. And in fact, it's probably when you perform it as early as possible. And for cerebellar ICH, there's also indication when there's a bleeding that is higher than 15 milliliter. So I mentioned a lot mini-invasive surgery. And really, probably the surgical technique matters. And there are craniotomy with hematomal removal, mini-invasive surgery with stereotactic aspiration, endoscopy guided, minimally invasive plus RTPA, transsulcal parafascicular, mini craniotomy. Well, you see, lots of device, and you have some example here of devices and also of sizes of devices. So here the brain path, that was what was used in Enrich. Here, this is endoscopy guided. This is what is used in the DIST, the Dutch trial. Here, this is what was used in the MISTI trial. So for the moment, the only positive data are from Enrich, but is this only associated to this kind of strategy? So for example, this kind of surgical strategy, we do not have access for the moment in France, and the device is very expensive. Or can we think that whatever you use as a device, the concept is really that you need to have a mini-invasive strategy as soon as possible and take out blood as much as possible. So what data do we have? Well, we have old data, which is the craniotomy, conventional craniotomy. It was the Stitch trials. And you could see that when you use this casual strategy of craniotomy, not casual, sorry, conventional strategy, well, the prognosis of surgery versus no surgery is exactly the same. And from this study, a subgroup that led to Stitch 2 suggested that there might be a better outcome when you have lobar ICH that are very close to the cortex. But you also have the MISTI strategy, so mini-invasive surgery with a stereotactic placement of a catheter, and then you inject in this catheter thrombolytic so that you are able to drain. I mean, it didn't meet the primary criteria of death or dependency. It suggested that it was quite tough to take out all the blood, and more studies are ongoing. And of course, you heard about this study 2 years ago, the Enrich study, which is rather difficult to understand from statistical perspective because it's based on Bayesian statistics. But when they included patients progressively, they saw that the probability of having an impact was only on the lobar category of patients, which might make sense if you think that really the goal is to have as less invasive strategy as possible. And so for deep ICH, it didn't meet the criteria for efficacy, but for lobar ICH, it raised quite a lot of hope, mentioning that those patients might benefit from mini-invasive surgery with this device. And you can see on the modified ranking scale for the first time a surgical strategy that was very encouraging. But a few months after that, another strategy, which is the MIND study that used another kind of device, failed to demonstrate the efficacy of the superiority of minimally invasive surgery versus medical management alone. They decided to stop recruitment because they considered that the ENRICH study had modified the clinical equipoise. And when they evaluated the impact of minimally invasive surgery on the subgroup of deep ICH, they showed that it was futile to continue the study, so they stopped after 236 patients and didn't show any significant impact. So I would say that the answer is not straightforward, and this is how we have put it in the European guidelines. In adults within 24 hours, and I may say that all data shows that you should probably do it as soon as possible. In adults within 24 hours after spontaneous supratentorial ICH onset, we suggest minimally invasive evacuation to reduce mortality and to improve outcome in adult with lobar ICH. But in deep ICH, it remains highly uncertain. But you see that the quality of evidence is low and the strength of recommendation is weak for intervention. In my institution, for example, in Lille, we very rarely perform surgery. When we perform surgery, our surgeon will go for lobar and will go for minimal craniotomy, but they do not use any device that you saw in those fancy studies. But it's probably the next big step in ICH management. We are not there yet. And we fight against hematoma expansion. We tried to remove as much blood as possible, but you saw all this cascade of events. And there's really an interface and a complex area of the brain which is around the bleeding that we may call perihematomal edema. I think it's much more complex than just edema, but let's use this term. For 1 ml of increase of absolute perihematomal edema volume, you increase the odds of poor functional outcome by 3%. So this is something quite that has an impact on outcome. And in guidelines, and those are the 2022 American guidelines, you see that early prophylactic hyperosmolar therapy for improving outcome is not established, and bolus of hyperosmolar therapy may be considered for transiently reducing ICP. So either you use it because you go to surgery right after that, otherwise it doesn't work. And corticoid should not be administered. So basically, there's not a lot you can do at present. And And it really shows that we need to find something else. And so, for example, maybe I can go back just 1 minute, but for example, what we are aiming now is to use diroximel fumarate, and we are starting a clinical trial next week, in fact, so early May. And we're using it to decrease perihematomal edema versus placebo. And it's a proof of concept. So let's see if we have more target and more options in the near future. So one single target, as you saw, is not enough. And you really have to promote the concept of care bundle. It has been demonstrated in Interact 3 when you have an in-house protocol with target systolic blood pressure below 140 within 1 hour. Non-diabetic patients, you define a target of blood glucose level between 1.1 and 1.4. For diabetic patients, you target something slightly higher, between 1.4 and 1.8 gram per liter. You don't want any fever in your patients, and if you have oral anticoagulant, you reverse VKA by PCC, sometimes transfusion plasma, we don't use it, and vitamin K, and you target an INR below 1.5 in 1 hour. This was in this study. We know now that for direct oral anticoagulant, you also use PCC if necessary. So you see, there was this goal of time is brain, the concept of a golden hour, and those targets should be treated during 7 days. And this strategy in more than 7,000 patients worked. You can see here the systolic blood pressure and the difference between the two groups. The control group in red, the intervention group in blue. You also see it with on diastolic and also on blood glucose level. When you apply this concept, you can see that patients with in the intervention group have a better outcome, including reduce of death, but also reduction of functional dependency. So really with a great impact, as you can see here on the odds ratio. So this care bundle strategy, it works. And to conclude, to really implement this strategy of having different targets for our patients in a stroke unit, you should develop an ICH checklist, and this is, for example, what we just published is for example, the A, B, C, D, E, F, G. A for anticoagulation reversal, start as soon as possible, complete reversal within 60 minutes after admission. B, blood pressure lowering, set a target, systolic blood pressure, achieve the target within 60 minutes. C, the care setting, it should be in a stroke unit or in a neuro-intensive care unit. D, very, very important, delay prognostication, gives full medical support, avoid premature limitations or withdrawal of life-sustaining therapy too early, 24 hours minimum, sometimes 48 hours is necessary. E, evacuation. You should ask the question, are there criteria to identify patients that must receive a neurosurgery consult? But it's not the first step, it's after all the other things have been performed, then you can request a consult. Drainage of intraventricular hemorrhage is something very important to keep in mind in some patients, and sometimes mini-invasive surgery. F, fever treatment. G, glucose management. protocols to manage optimally those ICH patients works. You saw it in the Lancet publication. You can also promote early alert and rapid admission for ICH patients with an in-house ICH code, because time is brain in ICH2. And monitoring help to reduce door-to-treatment times, improve adherence to guidelines, share protocols between institutions. In fact, care about those ICH patients rather than just thinking that this is an ICH. It's not a priority for us neurologists because there's nothing to do for those patients. So with that, I'd like to end my talk. I think ICH is really a very nice topic for research, but also for clinical fellowship. If you are interested in doing a clinical or a research fellowship, we have opportunities in Lille, in the north of France, and en route for the hemorrhagic stroke revolution. Thank you for your attention.
The next lecture is by Professor Rustam Al-Shahi Salman from the United Kingdom, Professor of Clinical Neurology at the University of Edinburgh and leader of the RUSH program on intracranial hemorrhage, who will present on practical approaches to open and minimally invasive evacuation of intracerebral hemorrhage.
Well, good afternoon, everybody, and thank you very much for inviting me to speak at your Kyiv Stroke Summit. I'm sorry that I can't be with you there in person, but greetings to everybody from Edinburgh in Scotland. So my name is Rustam Al-Shahi Salman, and I'm a neurologist in Edinburgh. I practice in the stroke service, and I'm a professor of clinical neurology at the university. I also do clinical trials for people with various vascular conditions, and I'm the clinical director of our clinical trials unit here and the network of clinical trials units in the UK. So I come to this talk with a desire to have the best available evidence to inform my clinical practice, and when it comes to treatments, that should be done in clinical trials. So I'm going to talk to you today about practical guidance on open and minimally invasive surgery for stroke due to intracerebral hemorrhage, which is the title I've been given. So first of all, my disclosures. Well, I'm paid by the University of Edinburgh, our state health service, and by the network of clinical trials units in the UK. The grants and consultancies that I have are paid to my employer to enable me to do research. And perhaps it's also important to say I have some non-financial disclosures. So I'm interested in anything that bleeds in the brain, including arteriovenous malformations, which led me to be involved as one of the leaders of the randomized trial of unruptured brain arteriovenous malformation treatment, which controversially, in many neurosurgeons' eyes, showed harm from treatment of unruptured AVMs compared with medical management over about 6 years of follow-up in the randomized trial that we did, which was published in the Lancet in 2014. This, of course, did answer the question about the early risks of intervention for AVMs, but unfortunately, the NIH in the USA never gave us funding to answer questions about the long-term outcome for patients, which of course is what we all think about when making treatment decisions. But this led me to be cautious about recommending intervention, and this is a view shared by many eminent neurosurgeons, including Henry Marsh, whose book you may have read, Do No Harm, where we need to make really careful judgments about who we use surgery for and who we do not. So you might think that I'm a typical neurologist who doesn't want to treat patients. And yes, it's true. My main disclosure for this talk is that I am not a neurosurgeon. But I also don't think that I am a stereotypical neurologist, especially when it comes to intracerebral hemorrhage. This is the caricature of a neurologist written by Richard Smith, the editor of the British Medical Journal back in 1999, of a brilliant, forgetful man with a bulging cranium, a loud bow tie, who reads Cicero in Latin for pleasure, hums Haydn sonatas, and talks with ease about bits of the brain you'd forgotten existed, adores diagnosis and rare syndromes, and most importantly, never bothers about treatment. I certainly am not a neurologist in that respect, because intracerebral hemorrhage is a condition where the outcome does need to be improved by treatment. So you asked me to talk about what surgical evacuation is, and certainly in the United Kingdom, when it comes to treating intracerebral hemorrhage, surgical evacuation is what the neurosurgeon does when you refer a patient to them with intracerebral hemorrhage. They run away and generally don't want to operate on them. But in seriousness, what do we mean by neurosurgical evacuation for this talk today? Well, I think it can involve a variety of techniques. So the first is hemicraniectomy, which of course is really decompression, and I'll mention that in a moment. It usually doesn't involve evacuation of the hemorrhage as well, but it may do sometimes. And then, of course, the more traditional approaches are a craniotomy with a bone flap and evacuation of the hemorrhage, or perhaps more minimally invasive techniques involving stereotactic aspiration in its different forms. And this is the growing trend for minimally invasive surgical techniques, usually done through very small bone windows, with devices of various different sizes. And you can see here the craniopuncture needle is the smallest of those. Then there's the MISTI device that was used in the MISTI trial, followed by the Artemis device, which is more of an endoscopic technique, and other endoscopy-assisted techniques. There's the Aurora Surgiscope and the BrainPath endoport system that was used in one of the more recent trials. So you see these are all relatively small bore devices, up to 15 millimeters, but as small as 3 millimeters, that have been used in various different trials of minimally invasive surgery compared with open resection using craniotomy. So if we are going to use these techniques, what benefits are we looking for? Well, you'll be familiar with the modified Rankin scale score, ranging from a score of 0, which implies no symptoms, to 6, implying death, and various other scores in between, indicating people's disability. And of course, what we generally want to do is prevent moderate, moderately severe, and severe disability after stroke. We want to keep people walking, even if they may have symptoms, and keep them as independent as possible. So usually a modified Rankin scale score of 0, 1, or 2 is what we seek in these trials. However, a lot of the time, patients who suffer intracerebral hemorrhage are already dependent on others before they have the bleed. Many of them have comorbidities that affect their day-to-day life, and which mean they aren't included in trials that are seeking to prevent that outcome. You can't include people who already have the outcome of interest. And one of the concerns in the literature has been that by doing surgery, we prevent people from dying. We may save a life, only to leave them severely disabled. And you'll be familiar with this concern from the randomized trials of hemicraniectomy that were done for acute ischemic stroke. But of course, when you ask stroke survivors what sort of outcome they're looking for, of course, they would all like no symptoms But many of the people who survived in the craniectomy trials were happy to be alive despite moderately severe or severe disability. So we should not judge this as doctors. It is an individual decision about what sort of outcome our patients would be happy with after treatment. So we really need to look in a nuanced way at what happens in trials of these interventions. So let's take the first of those types of surgical evacuation I referred to, that's decompressive craniectomy. And this is the SWITCH trial, which was published a couple of years ago in The Lancet, of hemicraniectomy for deep supratentorial intracerebral hemorrhage. And this was without evacuation of the hemorrhage. And almost 200 people were randomized in this trial. And as far as I'm aware, there aren't any other trials of this intervention. And this shows you the modified Rankin scale score ranging from dark blue, 0, all the way to red, 6, no symptoms to death. And what you can see here is that in both treatment groups in this trial, everybody at least was mildly disabled with a modified Rankin scale of 2 as an outcome, which tells you about how severe supratentorial deep intracerebral hemorrhage is, usually leaving people with deficits and poor outcome. And what the trial showed was that there was a nearly statistically significant reduction in death or severe disability with decompressive craniectomy versus best medical treatment. So 44% of people after decompressive craniectomy were dead or disabled, compared with 58% of people after best medical treatment. This was a very difficult trial to recruit to and unfortunately did not achieve its stated sample size because many people believed they knew what the outcome would be and did not randomize patients. And this is perhaps a good example of a trial where we wish twice as many patients had been recruited to make us really sure about whether this is a real result and that there is a reduction in death and severe disability with decompressive craniectomy or not. So let's think about all other types of surgery now. So this is surgery with craniotomy or minimally invasive surgery. I'm going to show you findings from the Cochrane review of randomized control trials of these techniques, which was last updated and published in 2025. For these other types of surgery, good functional outcome was measured in various different ways. So it wasn't just using the modified Rankin scale score, where a score of 3 or less was taken to indicate moderate to no disability, but also the Glasgow Outcome Scale, the extended Glasgow Outcome Scale, and the Bartel Index. So all these various different outcome measures across trials were harmonized into this definition of moderate to no disability, and this was used as the outcome to assess them all. Not a perfect approach, but under the circumstances, the best compromise for meta-analyzing all the available evidence. And what you can see here is that in all 18 randomized control trials, there was an improvement in the proportion of people with good functional outcome across all trials, with a relative risk of good functional outcome of 1.3, a 30% increase, relative increase in good functional outcome. And when you look at these trials according to the type of technique that was used, in the trials that used craniotomy and open surgical evacuation, there was a non-significant improvement in functional outcome. The 95% confidence interval around that relative risk of 1.41 overlapped 1 and was therefore not significant. However, in the 10 randomized control trials with more than 2,000 people who had some form of minimally invasive surgery, the increase in the proportion of people with good functional outcome was statistically significant. The lower bound of the 95% confidence interval was greater than 1. And here you see the randomized trials of minimally invasive surgery and the effect on death across all of these trials, done using various different techniques over various different periods of time, ranging from trials in the 1980s, early on, that were quite small, all the way through to the ENRICH trial in 2024. There is a reduction of death with this technique when all of these trials are combined. Now let's look at good functional outcome. And this shows you across all of those trials where this was reported, an increase in the chance of good functional outcome with this variety of minimally invasive surgical techniques. So these are the data that lead me to be supportive of minimally invasive surgery, although we need to be careful because this is several different types of technique across these trials. Many of the trials, as you can see, are small in their total sample size, and they've used different types of functional outcome measure at different time points. So based on that evidence, what do our most recent European Stroke Organization guidelines say? These were published at the end of last year, and the evidence-based recommendation was based on all of these trials that I've just shown you, but we determined the overall quality of the evidence to be low because of the design problems with the trials that I've told you about, and that our overall strength of recommendation was weak in favor of surgery. And in particular, we were in favor of minimally invasive evacuation of the hematoma being done within 24 hours of onset of the hemorrhage to both reduce death and improve functional outcome after lobar hemorrhage. However, we feel the effect in deep hematomas remains uncertain, especially after the ENRICH trial, in which recruitment of that group was stopped. So we feel that more randomized trials are needed to confirm these findings and determine for sure what should be done with people with deep supratentorial hemorrhage. And this guideline was prepared, I should say, in collaboration with the European Association of Neurosurgical Societies as well. So this is a consensus guideline recommendation from neurosurgeons and neurologists. So there are ongoing randomized control trials of minimally invasive surgery, and many of these should be reporting soon. You see two trials from China involving stereotactic aspiration and some type of thrombolytic drug. And these trials are recruiting about 800 patients in total. The Heal Me trial is an endoscopic MIS trial using Artemis, that's a feasibility study involving only 16 patients. You can see two other trials in China looking for 100 and 560 patients using minimally invasive surgery with urokinase or endoscopy in one case. And those are not the only trials. There are others that will be coming later on, with a neuronavigation trial expected from China in 2027, and a trial in China guided by diffusion tensor imaging, tractography on basal ganglia hemorrhages, which I think is an interesting approach, recognizing the disability that these bleeds can cause and surgery can cause if we don't consider the path of the tracts carefully. There are ongoing studies using the surgiscope, endoscopy, craniopuncture, and so on, that are all comparing these interventions against medical management in many other hundreds of patients. So I hope that within the next 3 years or so, we'll have some really definitive randomized control trials telling us whether we should be using minimally invasive surgery for sure and in which patients. So what are my conclusions on practical guidance on open and minimally invasive intracerebral hemorrhage evacuation? Well, I think the data in the Cochrane review show that minimally invasive surgery seems preferable to open craniotomy approaches and should be used wherever possible. And that's because minimally invasive surgery probably reduces all-cause mortality. It was statistically significant, but the evidence is only of moderate certainty because of the design differences in the trials and their quality. Also because minimally invasive surgery may increase the chance of good functional outcome. And again, we feel there's low certainty evidence there because of the different ways in which outcome was measured and the different time points, as well as the overall quality of the design of these trials. But the ongoing trials that I've shown you that should hopefully report in within 4 years or so by 2030 should settle this issue. But finally, there do remain uncertainties, not just about whether we should or should not use minimally invasive surgery, but also some uncertainties about whether we should only be considering the topography, in other words, only lobar intracerebral hemorrhage and not deep. We still need to know about both groups, and it might just be that one approach works well for lobar hemorrhage, but a more nuanced approach for deeper bleeds is needed, potentially including tractography, which is another consideration for future trials in systems where this can be done. The technique is important. I've shown you the many different minimally invasive surgery techniques, and whether one is superior to another remains to be determined. Also, there are different time windows in the ongoing trials, and we remain uncertain about whether we should be intervening early, before somebody's GCS has dropped, almost as a preventative intervention, or whether we should be waiting until GCS drops to force the neurologist and the neurosurgeon to recommend surgery and do surgery then. And several of the trials are investigating earlier time windows for recruitment. For example, the Dutch trial DIST is investigating an 8-hour time window. And then also we need to standardize our outcome assessments. We need to use the same scale across the different trials so they can be combinable, and also consider when we measure the outcome. Should we be measuring it early in everybody, like we do in ischemic stroke trials at about 90 days, or should we actually be waiting for longer? And the trajectory of functional recovery after intracerebral hemorrhage seems to be longer than after ischemic stroke. In other words, it takes more time for people to recover and reach a plateau after intracerebral hemorrhage than after ischemic stroke, suggesting that the time window for primary outcome assessment after intracerebral hemorrhage should be longer than the traditional 90 days or 3 months, and possibly 6 months or even 1 year. So thank you very much indeed for your attention. I hope this has helped with some simple messages about surgical evacuation for hemorrhage from a neurologist. I wish you all the very best for the rest of your Kyiv Stroke Summit. Thank you for your attention.
The next lecture is by Professor Ralph Cockrow from Switzerland, Director of the Microneurosurgery Center at Hirslanden Hospital in Zurich, and an expert in neurosurgical care who will discuss the evidence and principles of decompressive hemicraniectomy.
Yes, hello everyone. My name is Professor Cockrow. I'm a neurosurgeon from Zurich, Switzerland, and it's my pleasure and honor to give this talk about decompressive hemicraniectomy. It's a neurosurgical perspective. We all know that blood clots of various origins can cause ischemic stroke, and ischemic stroke is something serious. It's the second largest cause of death worldwide. It causes a lot of disability, and in 2016 there were 14 million cases of new strokes, and about 70% of those are ischemic strokes. A malignant stroke is a stroke that affects all or most of the MCA territory, and 10% of MCA infarcts are malignant strokes. There are radiographic features that are associated with the development of a malignant stroke, which is early demarcation of more than half of the MCA territory, which is a carotid T occlusion sign, which is an infarct volume of larger than 220 milliliters, and a midline shift, an early midline shift of more than 4 millimeters. Serum biomarkers like glucose levels and blood counts, hemoglobin, and so on, none of those reliably predict the development of a malignant edema and malignant infarction. So the idea of removing a large portion of the skull to generate simply space for the swollen brain to expand has been around for many years, and the concept is quite straightforward. We are talking about a large question mark shaped skin incision to achieve a frontotemporal parietal craniectomy of at least 12 to 13 centimeters or 10 times 12 centimeters in dimensions, and it is achieved by putting several burr holes after the skin incision and then opening the dura in a cross section shape. You would usually leave the arachnoid, which is expandable, intact, but simply opening the dura, the brain can expand, and you can see that during surgery often, of course. And then you would close the skin on the mildly or loosely approximated, thank you, dura. There's usually not much risk of CSF leak after the surgery because you leave the arachnoid intact. Like in this picture, you can see the shiny arachnoid and the leaves of the opened dura. So the big question is when or if one should consider a decompressive craniectomy. What is the evidence? There are 8 randomized controlled trials with 365 patients currently available. I'm sure you've heard most of the names. And in 2007, Vahidi and colleagues did a pooled analysis on 3 of the largest of those trials, Decimal, Destiny, and Hamlet. And the inclusion criteria of those were, in Destiny and Hamlet, were more than 66% of MCA territory infarcted, or in Decimal it was larger than 145 cubic centimeters. The time of surgery was between 12 hours and 96 hours. The patients were all younger than 60 years of age, and the technique, the surgical technique, was a craniectomy larger, or at least 12 centimeters in diameter, as shown just before. So, and then they combined those three trials, as I said, and that's a very interesting graph that resulted in this pooled analysis showing conservative treatment versus surgery. And you can see that in conservative treatment, 71 of the stroke patients died. And of those who survived, those who had severe or moderately severe disability, which is MRS 4 and 5, were actually only 7%. And 21% survived with MRS 2 and 3. So it's essentially a little bit like a binary outcome. A lot more than 2/3 don't make it. And those who survive are either somehow okay, and only a relatively small portions are severely disabled, MRS 4 and 5. Now, in the surgery group, the most striking thing is that surgery does save a lot of lives. The mortality is reduced dramatically from 71% to 22%. But the amount of patients with MRS 4 and 5, which was previously 7%, went up to 35%, so goes up by the factor of 5. So essentially, you are doing surgery, you do save a lot of lives, you also have a lot more good outcome, which of course also needs to be noted, which is 21% here, and you practically double that, right? And but you do also produce severe disability cases. So, well, I just leave it as such here, and I will continue, and we can reflect on that a little bit later. So recently, in April 2021, Lin et al. Published a stroke paper. It's a review. It's also in portion a meta-analysis. Decompressive hemicraniectomy for large hemispheric strokes. And they included all those 8 studies. They looked at those, and 6 of those trials they included in this meta-analysis. And the most striking difference to the paper we discussed previously is that the additional 3 randomized controlled trials, which they included, they had enrolled patients that were older than 60 years of age. And they came up with this analysis, with these results. The lower one, this is the one that we looked at previously. And now if you compare it, those are the 6 studies, and 3 of them included older patients. Again, same result, 71% in the conservative arm passed away. And the degree, the amount of severe disability went up a little bit compared to 16%. And in the surgical group, yes, also there was a great reduction of mortality from 70% to 30%. So again, it's less than half. And but you do produce with surgery. Nearly half of your patients are severely or moderately to severely disabled. So again, you spread out the clinical outcome by doing surgery. You do increase good results, you increase bad results, and you save lives. Okay, that's the situation. The timing of surgery has been discussed. Decimal Destiny and Hamlet show that there is a statistical benefit if the surgery happens in the first 48 hours. Dasenbrock found out in 2017 in a large analysis that it is of minor importance when you do surgery if in that interval of not doing anything before surgery, there is no clinical progression. As we said, in older patients, there is a higher likelihood of poor outcome of MRS4 and 5, and also older patients often are less likely to accept an unfavorable outcome. With respect to, do I do surgery on dominant hemispheric infarcts? There is no clear answer to that. Studies have shown that patients with aphasia, with strokes in the dominant hemisphere, do not necessarily show reduced long-term satisfaction compared to those in non-dominant infarcts. And also it needs to be noted that that the recovery of language can sometimes take years, and patients are often not totally aphasic, but develop some forms of communication, also verbal communication, and again that can improve over years. So overall, there is no evidence that suggests that the patients who had a stroke in the dominant hemisphere and who had surgical decompression are less satisfied with the overall outcome. Complications of surgery, yes, early complications, external brain herniation, yes, hemorrhages, infection, seizures, late complication, also seizures. There's different data on seizures that reach levels of like 10%, 20%, some say 30%, I think is too high. The sunken bone flap and then the communicating hydrocephalus, yes, about 5, maybe 10% of cases that were operated on, also with a cranioplasty afterwards, do require a VP shunt. The mechanism is not entirely clear. It's usually a communicating hydrocephalus. That leads us to the topic of cranioplasty. A cranioplasty can be done by preserving the bone flap. If you are at an institution where the freezing, the permanent freezing of a bone flap at -80 degrees can be guaranteed, there's no interruption of freezing at some point, right? Little devices that can monitor that. Then I think it's a great option to use the deep frozen bone flap. Or you You can use a alloplastic, a titanium, or plastic synthetic material to reconstruct the bone later on. You can also do that later on by 3D CT and exact planning of the implant. So it's a custom-made implant made to fit. There's different materials available for that. I have great experiences with that. The timing of a cranioplasty, well, there's early cranioplasty and late cranioplasty. In various publications that has been like divided into those groups. I personally find that about 3 months is the right timing to do the cranioplasty. The brain is not swollen anymore, but it's also not sunken in dramatically, usually after about 10-12 weeks. And if you wait a much longer time, then the layer between the dura and the overlying skin becomes more difficult to dissect. So I personally find that about 3 months is a good time frame for the cranioplasty. Rame et al. He did an interesting published an interesting paper. I think it was in the Journal of Neurosurgery 2012, and so it's a meta-analysis of a couple of papers, and they looked at patient satisfaction, and they overall, to cut it short, overall they report that 77% of patients report satisfaction and would give consent for surgery retrospectively. That's interesting, and it also concurs with my observations of, well, coming to 25 years of neurosurgery. Those 77% were the ones that were able, all the caregivers were able to understand the question and provide an answer. So the paper is not entirely clear if the 77% also include the severely disabled ones. So it's like a across the board figure, but I think it's quite interesting. My personal experience is also that I had wheelchair-bound patients that I operated on, who I followed up after months and some after years, and you would think that they are like MRS 4 or even 5, and 5 is tricky, but 4 I would say there's a good amount of patients even being MRS 4, despite not being able to walk and need help in activities and daily activities, that still would say retrospectively that they would give consent again to do the surgery. So it's not so easy for outsiders, for doctors, for neurosurgeons and neurologists to judge on satisfaction in that moment when the decision is made, shall I do surgery or not? So the truth is that it's an interdisciplinary decision. You need to look at the individual that you are treating, at the general condition and other diagnoses, and you need to find out about the will of the patient. You need to talk to relatives. Overall, I think in question of doubt, go for it. That's my viewpoint, and I think over the past years, I had good experiences with establishing the indication for decompressive hemicraniectomy in the majority of cases, in those cases where there was a question of doubt, should we do it or should we not do it? Well, I wish this would have been live, because it would have been interesting to enter a discussion now. That's not possible, as we all know, but I hope it will be possible again in the future, and I'm looking forward to that. Goodbye from Zurich.
That brings us to the end of plenary session 3. We now move to plenary session 4, which will focus on new frontiers in cerebrovascular diseases. We begin with a lecture by Professor Alexandru Tsiskaridze from Georgia, a leading regional expert in stroke and secondary prevention and Dean of the Faculty of Medicine at Ivana Javakishvili Tbilisi State University, who will present on modern decision pathways in intracranial atherosclerotic disease.
Hello, my name is Alexandru Tsiskaridze. I'm professor of neurology at Tbilisi State University in Tbilisi, Georgia. It's a great pleasure and privilege to participate once again as a faculty member in the traditional Kyiv Summer Stroke Summit. I'm truly impressed by how the scientific quality and content of the meeting continue to grow year by year. The program covers a wide range of important topics in stroke prevention, diagnosis, and management, with contributions from leading experts from around the world. I would like to warmly congratulate our colleagues and organizers Yuri Flomin and Marina Gulieva for maintaining such a high standard. Although it's unfortunate that current circumstances of world hardships do not allow us to meet in person, I am confident that we'll gather again on site in the near future. I wish all the participants an engaging and informative meeting. Thank you very much. In the next couple of minutes, I will be speaking about stroke with intracranial atherosclerotic disease and overview some decision pathways related with diagnosis, prevention, and treatment. Let's first look at the location of intracranial atherosclerosis. Then the lesions, atherosclerotic lesions, can be located anywhere in the intracranial vascular bed, including internal cerebral, the carotid artery, middle cerebral artery, anterior cerebral artery, vertebral artery, basilar artery, and even posterior cerebral artery. And intracranial atherosclerotic disease, we know that this is an important cause of ischemic stroke, especially among Asian, Black, and Hispanic populations. It accounts for 8 to 15% of ischemic stroke in Caucasians, 15 to 29% in Blacks, 14 to 66% in Hispanics, 30 to 65% in Asians, and potential cause of this is genetic susceptibility of some racial and ethnic groups, as well as differences in the lifestyle and risk factor profiles between races. As to the risk factors, they are pretty the same as for general atherosclerotic disease, which can be divided on non-modifiable, such as age, race, and probably sex, and modifiable, like hypertension and hyperlipidemia or dyslipidemia, which both of those increase the risk of recurrent stroke significantly. Smoking and diabetes mellitus. There is also some correlation between risk factors and stenosis site, like basilar artery stenosis is more often seen in patients with higher age and hyperlipidemia. The MCA stenosis is more often seen in women and Black. while intracranial ICA stenosis in patients with diabetes. What about the mechanism of stroke in patients with intracranial atherosclerosis? There are three distinct mechanisms. First is the plaque rupture or hemorrhage in plaque, which leads to in situ thrombosis and occlusion, as well as in situ thrombosis with distal embolization. The plaque grow until hemodynamically significant level, which then cause a hemodynamic compromise in the distal vessels, leading to so-called border zone or watershed infarcts. And the third mechanism is branch occlusive disease, which is caused by non-stenotic plaque, which occludes the ostium of perforating or penetrating artery, and it can be result in the infarct, which is somehow similar in its shape and its appearance to lacunar infarct. So it's a lacunar infarct is almost the of this similar shape and appearance. However, it's different by its origin. So, few words about morphological basis of intracranial atherosclerosis. You can see here the eccentric plaque with lipid core and fibrous cape. And this is a stable plaque. You can see it here. And this is the hemorrhage, intraplaque hemorrhage with hemorrhagical component in the lipid core. And you can see here the critically narrowed lumen of this vessel. And here we can see the intraplaque ulceration or plaque rupture, which is caused by very thin fibrous cape. And the next one is the non-stenotic plaque. You can see it here, which occludes the ostium, the beginning of perforator. Any of mechanisms can be related to the specific stroke pattern. You can see here the hemispheric embolic infarcts caused by, in this case, left MCA stenosis. Another picture shows here the midbrain infarct caused by basilar artery stenosis, which occludes the perforator. And you can see here the infarct on DWI. And the third pattern is the border zone or watershed or hemodynamic infarct, in this case caused by left intracranial ICA stenosis. What about diagnosis of intracranial atherosclerosis? The gold standard is conventional angio or digital subtraction angiography, which is the most accurate measure of stenosis. It can differentiate occlusion from severe stenosis. We can nicely assess collaterals. However, there are some limitations because it's invasive. It comprises small but risk of periprocedural stroke. It's quite expensive. It's related to ionizing radiation. Can cause contrast nephropathy. Therefore, it's not too often used. More often used is CT angio, which is non-invasive method. It has very high accuracy for detection of high-grade stenosis, more than 50%. However, it's less accurate than digital subtraction angiography, and sometimes overestimates the degree of stenosis, and sometimes it's difficult to differentiate critical stenosis to occlusion. However, it has higher sensitivity and specificity than time of flight MRA, and therefore this is a preferred method for intracranial atherosclerotic disease diagnosis in many countries, including United States. It also causes ionizing radiation and can be related with contrast nephropathy. As was the MR angio with time of flight sequence and contrast enhanced, It is also like CT angio, is non-invasive. It has high accuracy for detection of stenosis, more than 50%, with high negative predictive value, but low positive predictive value. Less accurate than conventional angiography in evaluating the stenosis degree, and difficult to differentiate critical stenosis sometimes with occlusion. However, there is no ionizing radiation, but there are issues with patients having claustrophobia or having pacemakers or implants. And one of the modern approach is the high resolution MRI, which allows us to look at arterial wall. We can also assess stenosis grade, which has a good agreement with digital subtraction angiography stenosis grade. We can assess plaque morphology as well as vulnerability. We also can assess plaque burden, plaque location, and modeling patterns, and even identifying substenosic wall lesions which cause stroke without significant narrowing of the vessel, like embologenic non-stenosic plaque or branch atherosclerotic disease. And you can see here some of illustrations. There is a stable plaque. You can see here the fibroscape, and on the T2, T1 contrast inhibiting imaging, you can see here again the fibroscape as well as a lipid-rich core. And another picture is the ruptured plaque. You can see here irregularities on the cap, fibrous cape, as well as contrast enhancing in the T1 intravenous contrast-based MRI. There are some also examples in this picture. You can see MCA stenosis here with T2 MRI, high resolution MRI, and T1 contrast enhanced MRI, and very nice picture of non-stenotic plaque, which is located in the ostium of perforator, therefore causing the acute infarct in the pons. And also very good method of diagnosis of intracranial atherosclerosis is a transcranial Doppler, TCD, which allows to have the real-time flow into information. We can also detect microemboli. We can assess vasomotor reactivity. It has very high accuracy for detection of high-grade stenosis. This is non-invasive, safe, and cheap, but it also depends certainly on the operator dependency, and requires suitable temporal bone acoustic windows. We also have color-coded TC duplex, which is also a very good modality or good method of diagnosing intracranial atherosclerotic disease. However, it's not extensively used, and I will not go into the details. Now let's switch to the management of acute stroke caused by intracranial atherosclerosis. We use in these cases all the acute intervention which is recommended by the current guidelines, like thrombolysis or mechanical thrombectomy. But sometimes we have to use this so-called rescue therapy if unsuccessful thrombectomy, and this kind of rescue therapy might be 2B3A inhibitors like tyrofibin, or angioplasty with or without stenting. And if there is a minor stroke caused by intracranial atherosclerosis, we are using recommendations based on chance and point trials, which comprise using dual antiplatelet treatments with clopidogrel loading dose of 300 milligrams according to chance trial, or 600 milligrams according to point trial. Dual antiplatelets with ticagrelor and aspirin with ticagrelor loading dose of 180 milligrams according to the Thales study. As this can be used as an alternative in patients with loss of function of CYP2, C19, cytochrome system genetic polymorphism. We also can use the loading dose of aspirin if already the patient is on clopidogrel or other antiplatelet therapy. As to the other symptomatic other rescue therapy, if patient is still symptomatic or deteriorating, or there is an imaging signs of hemodynamic compromise, and in this case, the induced arterial hypertension can be used. And this is done by stopping existing blood pressure lowering therapy, administration of intravenous fluids, some of non-pharmacological procedures to raise blood pressure, like lying in the supine position. Some vasopressor agents can be used, but very carefully with close monitoring of blood pressure. And finally, the endovascular treatment with stenting and angioplasty. And we can now see here the result of so-called SAINT study, which analyzed data from 14 comprehensive stroke centers and compared data with rescue stenting with failed reperfusion. You can see here the nice shift towards better functional outcome in patients with rescue stenting, which is highly statistically significant. And subsequent meta-analysis confirms this kind of findings in terms of better effect of MRS 0 to 2 at 90 days, better recanalization parameters, the better effects on 90-day mortality, and almost the similar effects on symptomatic intracerebral hemorrhage, intracranial hemorrhage. However, not all these studies are positive. I would like to demonstrate one of the recent studies conducted in China. This is the Angel Reboot trial of bailout intracranial angioplasty or stenting as compared to the standard treatment. And you can see here no difference at 90 days in terms of efficacy and more complications compared with the standard treatment. However, more recent analysis of different registries show the beneficial effects, like rescue ICAS registry analysis with higher rate of successful reperfusion in patients with stenting, with higher rate of functional independence, with slightly higher rates of procedural complications with stenting, but without increased risk of symptomatic hemorrhage. Almost the similar results are coming from another registry. This is resistant international registry from North America and Europe. And more than 70% of patients showed successful recanalization after stenting, and successful recanalization was predictor of functional outcome at 90 days. So we can come up with a kind of decision pathway for acute ischemic stroke caused by intracranial atherosclerosis. You can see here that in patients with large vessel occlusion with underlying intracranial atherosclerosis, we can use either contrast aspiration thrombectomy or stent retriever. If there is a reocclusion, we can use rescue therapy with GB2B3A antagonist, or rescue angioplasty with or without stenting. And this is very recent study published in Stroke with a different approach for rescue endovascular treatment, first-line intracranial stent placement versus thrombectomy first, and then stent placement if needed. So you can see here just schematically, this is a kind of first-line intracranial stenting without any prior thrombectomy attempt. And another group is first-line endovascular thrombectomy. And if the refractory occlusion remains, there is rescue intracranial stenting stent placed. And what are the results? Some shift towards better outcome in patients with first stenting as to the rescue stenting in comparison to rescue stenting. However, this difference is not statistically significant. Now let's speak about secondary prevention in patients with stroke and intracranial atherosclerosis. This condition comprises very high risk of recurrence. From the classic VESIT trial, there was 19% of stroke recurrence in patients with high-grade stenosis, and this rate is much higher in the real world or in rich cohorts and approach 30%. What are the risk factors or predictors for increased risk? First of all, this is proximity from index stroke, and the high risk persists 3 to 12 months after that, and it's twice as higher. High-grade stenosis, 70% or more. Poor collaterals, border zone infarct pattern, previous subclinical infarcts, multiple subclinical DWI lesions, perfusion deficit on CT or MR perfusion, microembolic signals on TCD, or correlates of plaque instability on high-resolution MRI. As to the secondary prevention, first of all, we have to modify the modifiable risk factors, aggressively do that, and this is the data from Sampris trial medical arm, which implied very aggressive treatment of risk factors and had a very small number of outcomes of interest. Therefore, we can use this as a standard of care for secondary prevention. And this is, I'd like to name all these measures which we should done in these cases. This is a strict BP, blood pressure control, keeping systolic blood pressure below of 100 milligrams of mercury or even below if patients are diabetic. Lifestyle changes with quit of smoking, increasing physical activity, healthy diet, weight loss, and etc. Lowering low density cholesterol of below 70 milligrams per deciliter, or even below that, below 55 milligrams deciliters according to the current guidelines, and considering intracranial atherosclerosis as a very high-risk population, and management of blood glucose if patient is diabetic. As to the anti-thrombotic treatment, I'd like just to remind the classic VESIT study compared anticoagulation to antiplatelet treatment, anticoagulation with warfarin, with antiplatelet, with aspirin. And this is the meta-analysis of two studies. First is VESIT, another is small Spanish study. You can see here almost no effect in the prevention of strokes. However, there is detrimental effect in terms of major bleeding and mortality, which is much higher in patients with anticoagulation. Therefore, the recommendation of European Stroke Organization is against strong recommendation against oral anticoagulation over aspirin, unless there is another formal indication for anticoagulation. As to the single versus dual antiplatelet regimes, there are two approaches with cilostazol plus aspirin versus aspirin, and it was evaluated in TOS, Catharsis, and CSPS.com studies. You can see here the effect which favors intervention with dual antiplatelets, and another very well-known studies, Chance and Thales. Again, combination of ticagrelor and aspirin versus aspirin showed much better effect, statistically significant effect in terms of stroke recurrence. As to the safety profile was absolutely acceptable for cilostazol for dual antiplatelet regimes. Therefore, the recommendation is of the European Stroke Organization of 2022 is to use dual antiplatelet therapy or single antiplatelet therapy. And as to duration of antiplatelet therapy, we know that there were different durations in different studies, 21 days in Chance study, 30 days in Thales studies, and 3 months in SAMPRI studies. However, if we use the results of the treatment arm of SAMPRI studies, which showed very good, very few primary endpoint events, we can extrapolate that to the recommendation for duration, and the European Stroke Organization recommendation is that the optimal duration of dual antiplatelet, so it is not clear, but according to the indirect evidence, the suggestion is to prolong dual antiplatelet up to 90 days after the index event. Now we came to endovascular treatment for intracranial atherosclerotic disease, primary percutaneous transluminal angioplasty and stenting plus best medical treatment or best medical treatment alone, and 2 landmark studies, SAMPRI studies and VISIT studies, and you can see here that there is no benefit of using this type of intervention. Conversely, there is much more harm than benefit, with increasing risk of major bleeding, with not change overall mortality, therefore, and other safety endpoints and secondary endpoints also demonstrated harm by these interventions. Therefore, the recommendation of European Stroke Organization that in patients with TIAs or ischemic stroke related to high-grade stenosis due to intracranial atherosclerotic disease, recommendation is strong against angioplasty or stenting added to best medical treatment as a first-line treatment. Out of this recommendation, several papers and the results of research were released, and this is one of those, the CASIS trial, which was conducted in China. You can see here no difference in terms of decreasing risk of stroke or death in patients undergoing stenting or undergoing best medical therapy. This is on short term as well as on long term, with 7.4 years of median follow-up. You can see here almost the same figures of endpoints of interest. However, there is kind of intervention which might be potentially beneficial, and this is submaximal angioplasty. You can see here schematically what does it mean. This is kind of primary angioplasty and submaximal angioplasty, which with undersized balloon inflation, in contrast with primary angioplasty with full artery diameter balloon inflation. So this kind of submaximal angioplasty can be considered as a gentler method, doesn't allowing to the plaque to dislodge distally like a snow plowing effect, leading to distal embolization or occlusion of the penetrators, which leads to the poor outcome in these cases. And this is the only randomized control study, again, carried out in China, the BASIS trial. And you can see here quite impressive figures of much lower incidence of primary outcome event, which is stroke in patients with balloon angioplasty, as compared with aggressive medical management. However, there were increased rates of stroke or deaths at first 30 days, and after that, you can see here the nicely diverging Kaplan-Meier curves, showing the better outcome after this time frame for angioplasty with 4.4%. As compared with aggressive medical treatment comprising 13.5%. So the conclusion of the authors were that this kind of balloon angioplasty can be effective treatment for intracranial atherosclerotic lesions for stroke prevention. Although the risk of stroke or death within 30 days in this group should be considered in the clinical practice. Now, this study has some limitations. This was conducted in the high-volume Chinese centers, so it's difficult to generalize result in other populations. And there was quite a high proportion of border zone strokes, which itself in turn comprises high risk of stroke recurrence. Therefore, I think we need more data in order to use this method in a clinical routine practice. After this trial, this meta-analysis was published which included the BASIS trial. And if you will look at the short-term results of endovascular intervention, you can see here not very good effect, this which favors unfavorable outcome in terms of short-term risk of ischemic stroke, in terms of short-term risk of death or stroke, as well as short-term risk of increasing the risk of hemorrhagic stroke. So based on this not very optimistic data, can we think that there is no place for endovascular procedure in intracranial atherosclerotic disease for secondary prevention of stroke? However, this is not true. There is still a place for that in patients with recurrent stroke despite best medical treatment. And for this, for illustration of that, this is the nice case with recurrent strokes caused by basilar artery stenosis in posterior circulation, and after placement of the two wingspan stents, there were no recurrent events after 3-year follow-up. And this is another case with recurrent border zone strokes, infarcts in patients with high-grade MCA stenosis. And after, again, the wingspan stent placement, there is no stroke for the quite a long-term outcome. So the recommendation in these cases are to consider endovascular treatment, angioplasty with or without stenting as a rescue therapy in selected patients with symptomatic high-grade intracranial atherosclerotic disease after clinical recurrence despite best medical treatment. So to summarize that and to show it in this kind of graph, there is we can speak about the decision pathway for secondary prevention, which consists first of all by antithrombotics, with dual antiplatelet therapy for up to 3 months, followed by single antiplatelet agent, aggressive treatment of hyperlipidemia with high-intensity statins as a first line, ezetimibe or PCSK9 inhibitors can be added for can be beneficial for those who fail to reach the target of LDL 70 milligrams of this DL, or even lower, like 55 milligrams per deciliter. Aggressive treatment of hypertension by any medication, but with achieving the goal of 140 to 90 milligrams of mercury, or even lower in patients with diabetes. The treatment of diabetes with a combination of diet, insulin, or hypoglycemic agents, with the goal of glycated hemoglobin less than 7% for the MACE patient, and also the aggressive modification of lifestyle factors, which consist of minimum 10 minutes of moderate intensity aerobic activity, like walking, biking, etc., 4 times a week. Dietary changes, switching to a kind of Mediterranean style diet, and certainly counseling on smoking cessation. What about current and future perspectives? The new diagnostic technologies are under investigation right now, like intravascular ultrasound or optical coherence tomography. We have to intensify research with aim to reveal new clinical, serological, or imaging biomarkers which predict recurrence of stroke in intracranial atherosclerosis patients. Novel treatments should be focused and tailored specifically for these patients, like new generation devices and stents. Nowadays, 2 randomized controlled trials are undergoing, PSTAR and ICAROS trial for as a rescue therapy for unsuccessful thrombectomy, and some neurosurgical trial like neurosurgical approach, like indirect bypass can be an interesting way. And for demonstrating this, I like to show the recently published paper comparing drug-coated balloon for endovascular treatment for symptomatic intracranial stenotic disease with bare metal stent. And you can see here quite a nice result with lower 6 months restenosis in drug-coated balloon group, with lower 30-day and 1 year recurrence of ischemic event, again in the drug-coated balloon group. So it's quite promising approach, I would say. And this interesting neurosurgical method, so-called encephaloduroarteriosyngiosis, which is extensively used in patients with Moya disease. And we have just only well-conducted phase 2 study with single arm, unfortunately, and as a control, then was use the historical control from historical control from other trials. In this case, this method compared with best medical treatment showed much most potency in terms of decreasing the recurrent stroke. And you can see here that outcome is also in favor of using this indirect bypass method. And if we look at the subgroup analysis of the same trial in patients with border zone infarcts, and we remember that border zone infarcts comprised the most risk for recurrence in patients with intracranial atherosclerosis. You can see here only 11 outcome events of recurrent stroke as compared with 37 outcome events in patients without this method used. and nice recanalization after EDIS revascularization, I'm sorry, after EDIS surgery. So this method can be used as a potentially beneficial method. However, more data, we need more data from randomized control studies. And a few words about undergoing study. This is Captiva study, the phase 3 double-blind study with 3 arms in high-grade intracranial atherosclerotic disease for secondary stroke prevention, comparing 3 arms with ticagrelor plus aspirin with small dose rivaroxaban plus aspirin and clopidogrel plus aspirin, with projected enrollment of more than 1,600 patients. However, this is the recent information that NIH, who was the sponsor of the trial, halted one of the arm, especially the arm with rivaroxaban in combination with antiplatelet because of futility and increasing safety signals. Therefore, we will have just only 2 arms in this trial after final analysis. And at the end, I'd like to mention that there is a huge interest towards intracranial atherosclerosis and related stroke. And this is a consensus paper, a rise to consensus paper published recently in Stroke, with all these aspects considered and analyzed. I would recommend to go and to see this article and to consider all this approach which are given by the prominent experts of this field. And with this, I'd like to finish my presentation. I'd like to thank you for your attention.
Our next speaker is Dr. Larissa Panteleenko from Ukraine, research fellow at the Stroke Research Center, University College London, and associate professor at the Department of Neurology, Bogomolets National Medical University, who will address contemporary perspectives on cerebral amyloid angiopathy.
Good afternoon, colleagues. My name is Larissa Panteleenko. I'm a research fellow at the Stroke Research Center at University College London. I would like to thank the organizers of Kyiv Summer Stroke Summit for the invitation and the opportunity to share information on cerebral amyloid angiopathy, what is known about this condition, and to highlight some controversial issues regarding the management of patients with CAA. Today we will discuss the pathology and pathophysiology of CAA, how we diagnose CAA, and how we manage patients with this pathology. I will also briefly touch upon the unresolved issues and diagnostic and therapeutic dilemmas associated with this condition. As you know, CAA is a type of small vessel disease that affects the small arterioles, capillaries, and venules of the leptomeningeal and cortical vessels. From a pathomorphological perspective, CAA involves the accumulation of beta amyloid in the walls of these vessels. Beta amyloid is the waste product. It's formed from the amyloid precursor protein and has several isoforms, the most common of which are 42 amino acid isoform found in parenchymal deposits in Alzheimer's disease, and the 40 amino acid isoform, which accumulates predominantly in the vascular wall. Normally, part of beta amyloid is metabolized intracellularly via enzymatic systems, whilst the remainder is cleared via the perivascular spaces into the bloodstream. If the beta amyloid clearance process is disrupted, it accumulates in the central nervous system intracellularly in the form of senile plaques, as in Alzheimer's disease, or in the vascular wall of cortical and leptomeningeal vessels with the development of cerebral amyloid angiopathy. Progressive accumulation of beta amyloid in the vascular wall leads to gradual loss of smooth muscle cells in the vessels, and over time to the delamination of the vascular wall. This leads to weakness of vessels, making it fragile and consequently increasing the risk of intracerebral hemorrhage. Further accumulation of amyloid beta may lead to complete obliteration of lumen of arterioles. An alternative scenario is observed when, following the loss of smooth muscles in arterioles and remodeling of the vessel structure, the permeability of blood-brain barrier increases, leading to the leakage of blood proteins, primarily fibrin, into the perivascular space, activation of microglia and reactive astrocytosis, and the development of perivascular inflammation. This in turn leads to capture of amyloid beta by macrophages and even greater vascular permeability and fragility. These processes are observed to varying degrees in patients with CAA as the degrees progresses. Pathomorphological changes appear long before the first clinical and radiological manifestation of CAA. Koymans and colleagues proposed a timeline for the progression of cerebral amyloid angiopathy from subclinical pathology to clinical manifestation of the disease. Here you can see the stages which develop sequentially over the 2 to 3 decades. Initial amyloid deposition in the vessel due to impaired clearance, followed by changes in cerebrovascular physiology, then non-hemorrhagic brain lesions, and finally the appearance of hemorrhagic brain lesions. The last 2 stages manifest clinically precisely at these stages. It is predominantly at the final stage what we see when we see patients. Understanding the chronology of stages and the pathophysiology of the processes linking them is of significant importance for the search of interventions that could potentially modify the course of cerebral amyloid angiopathy. As demonstrated by systematic review by Jekyll and colleagues, which covered more than 170 pathomorphological studies, cerebral amyloid angiopathy is quite common among older people. In the general population, it is detected in 23% of cases. Among elderly individuals without cognitive impairment, this figure stands at 5%, whilst in patients with Alzheimer's disease, it rises to 48%. Regarding patients with hemorrhagic manifestations, it is known that 19% of patients with intracerebral hemorrhage, regardless of location, have CAA, while approximately half of those with lobar ICH do have CAA. Thus, CAA is common pathology. However, the available diagnostic tools which with high sensitivity and specificity like Boston and Edinburgh criteria have been validated predominantly for cases with hemorrhagic manifestation. Their effectiveness in patients without ICH, those with cognitive impairment alone, or incidental MRI findings request further investigation. Following the initial accumulation of amyloid beta in the vascular wall, the progression of disease may vary over time. Most subjects have an asymptomatic course of CAA, which is radiologically characterized by cerebral microbleeds, a white matter hyperintensity, and enlarged perivascular spaces in centrum semiovale. In other cases, the disease follows a distinct trajectory involving a clustered course where intracranial hemorrhages such as cortical subarachnoid hemorrhages, symptomatic and asymptomatic cerebral intracerebral hemorrhages occur in succession, followed by a period of inactivity. An increase of superficial cortical siderosis may also be observed. In this stage, other patients present with initial cluster of hemorrhagic event, followed by a period of progressive accumulation of superficial siderosis, white matter hyperintensities, enlarged perivascular spaces, and brain atrophy, leading to deterioration of neurological status. Some patients experience hemorrhagic episodes without an apparent tendency to cluster. A proportion of patients experience gradual neurological deterioration, predominantly of cognitive status, without clinically significant hemorrhagic events. These clinical variants of CAE reflect the heterogeneity of clinical progression of CAE. We see patients at the stage of clinical manifestation of the disease, which may be hemorrhagic or non-hemorrhagic. Hemorrhagic manifestation include lobar intracerebral hemorrhages and convex subarachnoid hemorrhages, which present as transient focal neurological episodes. Non-hemorrhagic manifestation include cognitive impairment, ranging from mild to severe, up to dementia, and CAE-related inflammation, which I will discuss later. You may encounter transient focal neurological episodes in A&E department, or patients may tell you about them retrospectively during your outpatient visit, Clinically, TFNE is difficult to distinguish from TIA or other transient neurological syndromes, such as migraine or focal epileptic seizures. Classic TFNE involves brief disturbances of motor, somatosensory, visual, or speech disturbances. Patients usually describe them as a combination of so-called negative symptoms, such as drooping of mouth corner, slurred speech, or numbness, which may resemble a transient ischemic attack, as well as positive symptoms such as tingling, crawling cessation, and so on. Symptoms migrate spatially. Starting in one place, they spread and change location, which might resemble focal epileptic seizure or migraine aura. The background for TFNE is convex subarachnoid hemorrhages originating from small superficial arterioles affected by amyloid beta. They differ significantly from aneurysmal subarachnoid hemorrhage in terms of location, volume, and clinical presentation. They do not cause thunderclap headaches, impaired consciousness, or meningeal signs. Thus, if a patient describes a picture of similar to TFNE, a thorough examination is required to establish the correct diagnosis. Your examination plan should include a CT scan and preferably MRI scan as well, with mandatory inclusion of FLAIR images and blood-sensitive sequences like SWI or gradient echo, which will show acute convexity subarachnoid hemorrhage, and or areas of superficial cortical siderosis on blood-sensitive images. Be sure to look for a correlation between the location of TFNE or subarachnoid hemorrhage, and siderosis, and patient's clinical symptoms. At present, a definitive diagnosis of CAE can only be confirmed by a pathological examination of the brain, autopsy, or biopsy. Ante-mortem diagnosis of the disease is based on clinical and radiological criteria, which are now in their third edition. These are the Boston criteria for CAE version 2.0. Criteria have also been developed for the diagnosis of CAE using CT scans in patients who have developed ICH. It's so-called Edinburgh criteria. Using the Boston criteria, we can diagnose definite, probable, and possible CAA. These criteria take into account the presence of relevant clinical syndrome, namely the occurrence of spontaneous lobar ICH or TFNE cognitive syndrome in patients over the age of 50. Compared with previous version of criteria, these criteria take into account not only hemorrhagic MRI markers, but also non-hemorrhagic ones, the presence of enlarged perivascular spaces in the centrum semiovale, multi-spot pattern of white matter hyperintensity. Currently, the Boston criteria 2.0 are the gold standard for the diagnosis of CAA. However, it should be take in mind that the validation of this criteria required pathomorphological confirmation of the diagnosis. Consequently, patient had a more severe course of CAA leading to death, or had a large intracerebral hemorrhage requiring evacuation and biopsy. Consequently, the patients included in this analysis differ from the general population and from patients with a milder course of CAA, whom we typically see in clinical practice. For this reason, the sensitivity of this criteria is likely to be overestimated. The Edinburgh criteria for ICH were developed to confirm CAA in patients with acute hemorrhage. Given that CT scans are more readily available than MRI scans in the emergency settings for ICH, these criteria take into account the neurological features of ICH that are visible on CT scans. These features include the lobar location of ICH and the presence of so-called finger-like projections, which you can see in two right CT images of the illustration, as well as a subarachnoid extension of the hemorrhage. The presence of a subarachnoid extension in lobar hemorrhages has 89% sensitivity for moderate to severe CAA. Therefore, in the absence of this marker, CAA is, as the cause of lobar hemorrhage, is unlikely, but its presence cannot be ruled out. Therefore, in this case, to clarify the etiology of ICH, an MRI scan must be performed using a mandatory blood-sensitive mode. The presence of subarachnoid extension of hemorrhage and finger-like projections has almost 100 sensitivity, 100 specificity, meaning that the presence of these markers unequivocally indicates CAA associated with a lobar ICH. However, it is worth remembering that these criteria were validated for severe, fatal, large volume ICH. They may not be sufficiently sensitive for smaller volume ICH. Clinicians are most interested in the risk or calculation of ICH caused by cerebral amyloid angiopathy. It is known that overall, 1 in 5 cases of ICH are caused by CAA. And with regards to lobar ICH, CAA is the primary cause. The annual risk of developing an ICH in patients with CAA ranges from 7 to 10%. This risk significantly exceeds the incidence of ICH in the general population, which is approximately 1%. As for recurrent ICH, the risk in patients with CAA is significantly higher than in patients with other causes of ICH. According to data from a study conducted in our stroke research center, the risk of recurrent hemorrhage in patients with CAA is 17% in the first year following a first ICH and rise to 41% over 5 years. Let me remind you that the pattern of cerebral microbleeds, one of key radiological markers of small vessel disease, varies depending on the subtype. According to the Boston criteria, a patient with cerebral amyloid angiopathy should not have deep cerebral microbleeds, which are markers of arteriolosclerosis. At the same time, in clinical practice, a certain combination of both pathological processes is often observed. Among the hemorrhagic radiological biomarkers of CAA, superficial cortical siderosis is the most specific, provided that the other possible causes are ruled out. At the same time, it is also the most significant predictor of the risk of intracerebral hemorrhage. As mentioned earlier, the Boston criteria 2.0 are currently considered the gold standard for diagnosing cerebral amyloid angiopathy. Compared with earlier versions, they demonstrate greater sensitivity in identifying patients with CAA. At the same time, it is interesting to note that a comparison between the previous version of the criteria and their latest revision in predicting the risk of recurrent intracerebral hemorrhages showed that patients with CAA diagnosed solely based on additional non-hemorrhagic markers had an almost tenfold lower risk of recurrent intracerebral hemorrhage than patients with CAA identified using the Boston 1.5 criteria based on hemorrhagic markers. One possible explanation for the lower risk of intracerebral hemorrhage is that the non-hemorrhagic markers may correspond to stage 3 of CAA of the scale proposed by Koymans and colleagues, whereas the presence of hemorrhagic signs reflects stage 4, the most advanced phase of the disease, in which the vessels become more vulnerable and hemorrhage occurs directly. The course of CAA is characterized by the spatial and temporal clustering of ICH, which likely reflects alternating phases of increased disease activity and relative stabilization. With long-term follow-up, periods of disease activity can be identified, which manifests clinically and on neuroimaging as a series of intracerebral hemorrhages or episodes of cortical convex subarachnoid hemorrhages, followed by intervals of relative remission with a lower risk of new hemorrhagic events. There is currently no treatment for CAA. However, several studies are underway aimed at modifying the course of the disease. One promising area is a clinical trial of intrathecal administration of mivelsiran, small interfering RNA that targets the IPP mRNA, the precursor protein of beta amyloid, inhibiting its synthesis and potentially reducing the formation of beta amyloid. In parallel, significant progress has been made in the treatment of acute intracerebral hemorrhages, which will be discussed in more detail by other speakers of the summit. We can influence the risk of hemorrhagic complications of CAA through secondary prevention. To this end, at the specialist clinic in our research center at University College London, patients with CAA are provided with comprehensive recommendations, the key elements of which include maintaining blood pressure at 130/80 or below, if tolerated, and no contraindications, avoiding the use of antiplatelet agents and anticoagulants, as well as lifestyle modification and management of vascular risk factors. In addition, symptomatic treatment is provided depending on clinical manifestation of the disease. In particular, anticonvulsants may be used for transit focal neurological episodes, and in case where CAA is combined with Alzheimer's disease, anticholinesterase agents may be used to manage cognitive impairment. New guidelines on the management of CAA were published last year. They are in open access. I recommend that anyone interested in this topic and who sees patients with CAA in their practice should become familiar with these guidelines. They cover approaches to diagnosis, examination methods, and assessment of ICH risk in patients with CAA, approaches to use of antithrombotic drugs and vascular interventions, the management of vascular risk factors in this patients group, and management of various clinical manifestations of CAA, and diagnosis and treatment of CAA-related inflammation. The greatest dilemma in the management of CAA arises when prescribing anticoagulants and antiplatelet drugs to patients who require it. Generally speaking, these drugs should be avoided in CAA, but what should be done when a patient has indication for this use. For example, if the risk of ischemic stroke exceeds the risk of hemorrhagic stroke. If your patient has CAA, certain rules must be followed when prescribing them. Individual risk can be assessed based on data from relevant studies. This slide shows the diagram which can serve as a guide for clinical decision-making. So if a patient has only cerebral microbleeds without siderosis and requires antiplatelet therapy, there are generally no significant restrictions on its use. If anticoagulant therapy is required, DOACs should be preferred. More data have been accumulated regarding the safety of apixaban, but vitamin K antagonists should be avoided where possible. If patient has siderosis, our approach will depend on one hand on the extent of the siderosis, focal or disseminated, and on the other on the indication for treatment. In patients with focal siderosis, we prescribe antiplatelet agents in accordance with the indication for such therapy. And among anticoagulants, we again give preference to apixaban and avoid vitamin K antagonists. If possible, recommend left atrial appendage occlusion procedure. This may be a safe alternative to anticoagulation. In disseminated corticosiderosis, avoid dual antiplatelet therapy, exception being short-term use during stenting. Regarding anticoagulants, again, when possible, give preference to left atrial appendage occlusion procedure. If this is not possible, prescribe apixaban, but avoid vitamin K antagonists. Finally, I would like to address two additional controversial issues relating to CAA: the mechanism underlying hemorrhage in patients with CAA and the role of inflammation in its pathogenesis. Although CAA is common in the general elderly population, only a small proportion of affected individuals develop intracerebral hemorrhages. This suggests that the mere presence of beta amyloid within vessel wall is insufficient to cause ICH. I will therefore focus on inflammation associated with cerebral amyloid angiopathy as a distinct syndrome and its potential contribution to the development of hemorrhage. Thus, CAA-related inflammation is a clinical syndrome characterized by an autoimmune inflammatory response, the deposition of beta amyloid in the wall of brain's blood vessels. The classic clinical presentation of CAA-related inflammation is usually acute or subacute, accompanied by headache, behavioral changes, impaired consciousness, seizures, and sometimes focal neurological symptoms. Radiologically, we also observe a quite characteristic pattern, example of which is shown on the illustration. This involves the presence of asymmetric white matter hyperintensity signal on T2 or FLAIR images, sometimes with a mass effect consistent with vasogenic edema. As with sporadic CAA, a definitive diagnosis can only be established on the basis of biopsy. The existing criteria, which you can see on the screen, are highly specific, but not sufficiently sensitive. In practice, this diagnosis often remains a diagnosis of exclusion, and in complex cases still requires a brain biopsy. Treatment consists of pulse therapy with methylprednisolone, 1 gram for 5 days, followed by oral administration with a gradual reduction in dose over 3 to 4 months. It is interesting to note that not all patients show the classic symptomatic course of the disease. Radiological signs of CARI may be detected in asymptomatic patients or in patients with minimal symptomatic presentation of CA who have undergone MRI for other diagnostic purposes. Furthermore, a typical radiological picture with vasogenic edema is not observed in all cases, highlighting the need to expand the existing diagnostic criteria. Similar clinical and radiological manifestation may also be observed in patients receiving immunotherapy for Alzheimer's disease. Our observations of patients at our center and the identification of signs of inflammation across various subtypes of CA have led us to conclude that inflammation may not be a distinct subtype, but rather a pathological process that can accompany cerebral amyloid angiopathy of any etiology. Accordingly, the first step should be to determine the cause of the patient's CAA, whether it is sporadic, hereditary, or iatrogenic. Due to the time constraints, I will not dwell on individual causes. Next, it is necessary to determine whether inflammation is present or not. If inflammation is present, the final step is to assess its severity based on the clinical presentation and radiological findings, as well as histopathological data if available. Further studies are required to test this hypothetical model. A promising area for further research is the investigation of the potential role of inflammation in the development of intracerebral hemorrhages. At our center, using high-resolution contrast-enhanced MRI with visible imaging in patients with CAE and persistent TFNs, various combination of contrast enhancement in leptomeningeal, parenchymal, and small cortical arteries were identified, which may indicate a transient inflammatory process. Whether inflammation plays a role in the formation of ICH clusters requires further studies. We are currently conducting a study dedicated to assessing the role of inflammation in the development of recurrent ICH. If our hypothesis is confirmed, this could open up a new potential window for the prevention and treatment of ICH caused by cerebral angiopathy. Well, I hope I've managed to provide you with some new information that refresh your memory on what you already knew about cerebral amyloid angiopathy. You can see the take-home messages on your screen. I want to thank you to Prof. Waring and all my colleagues at UCL Stroke Research Center. If you have any questions or suggestions, my email address is displayed on your screen. Thank you for all your attention.
We close plenary session 4 with a lecture by Professor Yuri Flomin from Ukraine, head of the Stroke Center at Oblary Clinic in Kyiv and national stroke expert for the WHO country office in Ukraine, who will discuss safety and clinical considerations in secondary prevention after intracerebral hemorrhage.
Dear colleagues, today in the afternoon we are going to discuss secondary prevention after intracerebral hemorrhage and focus on safety, some clinical considerations and practical guidance, trying to navigate the thromboembolic and hemorrhagic tightrope. Let me start off with the background, which is slightly different that we used to think before. According to GBD 2023 data, the most recent data we have today, ICH, which stands for intracerebral hemorrhage, is about 30% of all acute strokes. Usually we used to think it's their proportion is slightly less. At the same time, it's responsible for up to 50% of stroke-related deaths and 50% of disability-adjusted life years lost due to stroke. In 2023, globally, there were almost 4 million cases of intracerebral hemorrhage. It caused 3.2 million deaths and 78.3 million disability-adjusted life years lost, dollars lost. The incidence globally on average was 48 per 100,000, while mortality was 39 per 100,000 population. In Ukraine, there were more than 17,000 cases of intracerebral hemorrhage, 12,000 deaths due to intracerebral hemorrhage, and 331 thousand dailies lost due to ICH. Incidence in Ukraine in 2023 was 44 per 100,000, and mortality was 31 per 100,000 population. So let me now switch to the core clinical dilemma we have in ICH. It appears that ICH is associated with 2 to 4-fold heightened risk of major cardiovascular events, including stroke, myocardial infarction, and vascular death. And major cardiovascular events lead to poor outcome after ICH. Actually, the risk of major cardiovascular events after ICH and ischemic stroke are similar. And in low middle income countries, they are up to 10% per year. The challenge is many ICH survivors have indications for antithrombotic treatments, which in turn can trigger rebleed. And now I'd like you to take a look at the recent Finnish study published a couple of years ago. The results of this study, the findings, they show that after ICH, the rate of the risk of ischemic stroke is increased. The risk of myocardial infarction is almost the same as in people who they had not suffered ICH. The risk of recurrent ICH is significantly increased, you see, compared with people who did not have ICH. And all major vascular events, MACE, probably know this abbreviation, MACE. The risk of MACE is significantly increased in people after ICH. And it brings us to this again, to core clinical dilemma. Despite this increased cardiovascular risk among ICH survivors, there is uncertainty about the use of secondary prevention strategies, such as antithrombotic or lipid-lowering medications, because of potentially increased risk of recurrent ICH. Current ICH guidelines do not provide definitive recommendations about the use of these medications, including the timing of initiation, which is best for the patient, potentially resulting in wide variation in the implementation of secondary cardiovascular prevention strategies after ICH. And that's why we chose this topic for our discussion today. What is not the matter of debate is the need for blood pressure control after ICH. Blood pressure control is the cornerstone of secondary prevention. And according to current guidelines, long-term blood pressure control is the single most effective intervention for secondary prevention in people who survived ICH. Target level of blood pressure, which is now recommended in the clinical guidelines, is below 130/80, millimeters hydrogram, at least according to the American Heart Association, American Stroke Association guideline. It's a class 1 recommendation. Aggressive reduction in the acute phase of intracerebral bleed to the level below 140, 130 is safe and may improve functional outcomes. Another clinical question, more debatable, more complex, is it safe to restart antiplatelet medications in patients after ICH? For a long time, it was considered not safe enough to recommend to start the patient on that medication. It was before their clinical trial with their name Restart. Restart or Stop Antithrombotic randomized trial included 537 participants with ICH and a prior history of ischemic vascular disease. It was shown that antiplatelet therapy significantly reduced the risk of major ischemic vascular disease and did not increase the risk of recurrent ICH at a median follow-up of 2 years. Adjusted hazard ratio of recurrence was 0.51. And not statistically significant, but suggesting notable trend towards safety. Now let's switch to anticoagulation after ICH. That's actually a big decision. Whether resuming or starting anticoagulation in patients with previous ICH is safe, improves survival, or effectively provides net benefit at present remains unknown. Oral anticoagulation significantly reduces major ischemic cardiovascular events, including ischemic stroke, pulmonary embolism, and myocardial infarction on the one hand. On the other hand, oral anticoagulation in these patients is associated with 2 to 4 fold increase in recurrent ICH. The key questions in this scenario is what was the ICH cause? What is the CHA2DS2-VAR score of the patient? And is his or her blood pressure well controlled? Coming to the cause and causal classification system of ICH, I'd like to present this publication from Annals of Neurology a couple of years ago, which is quite good from my perspective, classifications representing subtypes and etiology of ICH. In this class ICH classification, the authors they suggested several causes with the causes of ICH, such as arteriolosclerosis. And on the right side of this table, you can see well-defined characteristics of this subtype. So it's a pathologically proven arteriolosclerosis on brain biopsy or autopsy, or multiple hemorrhages, including intracerebral hemorrhages and cerebral microbleeds confined to the deep structures, basal ganglia, thalamus, brainstem, regions of the brain, and cerebellar hemorrhages, intracerebral hemorrhages or microbleeds, or single without ICH or cerebral microbleeds, deep ICH, and evidence of severe confluent white matter hyperintensity and all accunes in the deep regions of the brain. Another cause quite common is, especially in the elderly patients, is cerebral amyloid angiopathy. And well-defined characteristics of this subtype is pathologically proven cerebral amyloid angiopathy on the brain biopsy or autopsy, or multiple strictly lobar cortical or cortico-subcortical hemorrhages, including ICH, CMB, or superficial cortical siderosis, and age 55 years or older, and absence of other well-defined causes of ICH. The next etiological subtype of ICH is mixed cerebral small vessel disease. For this subtype, the well-defined characteristics include pathologically proven coexistence of arteriolosclerosis and cerebral amyloid angiopathy on brain biopsy or autopsy, or mixed hemorrhages, multiple brain hemorrhages, located both in lobar and deep regions. And other subtypes, etiological subtypes of ICH, they comprise other forms of cerebral small vessel disease, such as inherited small vessel disease, for instance, familial forms of cerebral amyloid angiopathy, CADASIL, and some other defined genetic mutations confirmed with genetic testing, well-demonstrated small vessel disease that does not fulfill all criteria for other small vessel disease subtypes. Example could include patients with multiple strictly lobar hemorrhage, but whose age is below 55 years. Other rare well-defined causes of small vessel disease, for example, post-radiation angiopathy. And a vast category of secondary causes of ICH. To this category etiological subtype, the following conditions belong, such as microvascular causes, brain arteriovenous malformations, intracranial aneurysms, dural arteriovenous fistula, and cavernous malformations, brain tumors, both primary tumors and metastases, hemostatic and hematologic disorders, such as severe thrombocytopenia, severe clotting factor deficiency, such as hemophilia, fibrinogenemia, etc. Cerebral venous thrombosis from local to or from systemic cause, the vasculitis and related vasculopathies, including CNS primary angiitis, systemic vasculitis, moya disease, and so on. And toxic influences such as cocaine, other sympathomimetic drugs. So the main clinical question we need to address before making any decision regarding the secondary prevention is risk stratification, taking into account lobar versus non-lobar intracerebral hemorrhage. On the left side of this slide, you can see the deep non-lobar versus lobar intracerebral hemorrhage. And on the right side, you see that annual recurrence risk in deep as hypertension-related intracerebral bleed is very relatively low, about 2%, while in non-deep, in lobar intracerebral hemorrhage, the annual recurrence risk can be up to 10%. So it makes huge difference. And in a recent Cochrane analysis, the conclusion were that the authors did not identify beneficial or hazardous effect of short-term prophylactic dose of parenteral anticoagulation. So we can be relatively sure providing medical prevention for deep vein thrombosis in the ICH patients, and a long-term oral antiplatelet therapy after ICH on important outcomes. Another conclusion was that although there was a significant reduction in MACE and all major occlusive vascular events after long-term treatment with therapeutic dose of oral anticoagulation for atrial fibrillation after ICH, the pooled estimates were imprecise. The certainty of evidence was only moderate, and effects on other important outcomes were uncertain. So the bottom line is that we need large randomized control trials with a low risk of bias to resolve the ongoing dilemmas about antithrombotic treatment after ICH. Let's now discuss the lipid lowering therapy in patients after ACH. And those of you who have looked at the literature they probably have noticed that it's a never-ending debate. The controversy surrounding the use of lipid lowering therapies, in particular statins, still goes on. Dedicated prospective and randomized studies in patients with ICH are needed to guide the best strategy for lipid lowering in this forgotten and understudied population. That's the conclusion of the paper published in the Journal of American Heart Association in 2024. These lipid lowering therapies, and in particular statins, are called the double-edged sword in patients after ACH. The statin exposure actually was associated, according to the systematic review and meta-analysis, associated with a lower risk of both any stroke and ischemic stroke, but was not associated with the recurrent ICH, as you see on this slide. Systematic review and meta-analysis of 30 studies. Another study is that in which there were more than 40,000 participants. It was shown that statins significantly reduced overall mortality in patients with ICH in the past. And the size of the effect relative risk reduction was about 40%. So now we have the database showing that probably in the majority of ICH patients, especially in patients with deep ICH, statins are safe and beneficial. So now let's move to practical guidance, which is in the clinical guidelines and also different sources. And in our clinical practice, we usually stick to this practical guidance and do what is suggested in the following. Antiplatelet guidance. Restarting antiplatelets can be considered when ischemic risk is substantial. So after a while, in patients with who suffered ICH, we evaluate, assess the ischemic risk. And if it's substantial, then we consider starting or resuming antiplatelets in these patients. Actually, there's no strong evidence of elevated recurrent ICH risk in non-lobar cases. Timing usually 2 to 4 to 8 weeks after stabilization of the patient. Regarding the oral anticoagulants, the most challenging questions are when and how. So usually on weeks 1 and 2, they are avoided. And starting from week 4 to 8, we can consider that the starting or resuming oral anticoagulants in patients who need this preventive treatment, such as patients with AFib. We need to find out their plausible course or subtype of etiological subtype of ICH, and make sure that the patient's blood pressure is under control. And we always, in the recent years, we always prefer the direct oral anticoagulants, not warfarin, if the situation allows. If it's a lobar hemorrhage and risk of bleeding is very high, so we consider surgical alternatives such as left atrial appendage occlusion. Regarding statins, continuation is generally acceptable when cardiovascular risk is high. We exercise caution in lobar and cerebral amyloid angiopathy related ICH, and there is no strong recommendation in the guidelines, and at least in the European Stroke Organization guideline, to discontinue statins systemically. What the real clinical practice, real world clinical practice shows? It's just one example. It's from the very well-known American quality improvement program, Get With The Guidelines Stroke. In this program, there is a registry that shows this real-world practice, and these bars are from this from the publication based on the Get With The Guidelines Stroke Registry. And it shows that in patients after ICH in the United States, about 10% they receive antiplatelets, more than 30% of the patients receive statins, and just about 5% are prescribed oral anticoagulants. So let me summarize what we have just discussed. The cornerstone of secondary prevention is blood pressure control with target level below 130/80. We need to distinguish lobar and deep ICH. In case of deep ICH, we can and probably should consider there's antiplatelets and statins, which is usually safe and appropriate. While in lobar cerebral amyloid angiopathy related ICH, we should be very cautious and carefully weigh absolute ischemic risk and risk and assess risk and benefit ratio. Use of direct oral anticoagulants over warfarin is strongly recommended if the oral anticoagulation is needed, and it's usually a multidisciplinary approach. We should involve our colleagues cardiologists to discuss it on case-by-case basis and make consensus decisions. So in conclusion, antihypertensive drugs almost always, almost in all cases after ICH. Antiplatelets, selective restart is evidence-based. Anticoagulants, oral anticoagulants, weigh risk and benefits. Statins, continuation appropriate when there's clear indication for this preventive treatment, and the decision-making should be individualized. Special attention to patients with cerebral amyloid angiopathy related lobar ICH bleeds. And always remember that our major goal is do no harm. Thank you for your attention.
This brings us to the end of plenary session 4. Thank you for joining us today. We look forward to seeing you tomorrow for key updates in stroke neurology and modern approaches to stroke diagnosis and prevention.